Very good evening, respected seniors and colleagues. Today I am going to discuss about ticagrelor and current evidence in ACS. ACS is acute coronary syndromes. Ticagrelor is indicated for reducing the rate of thrombotic cardiovascular events in patients with acute coronary syndromes. It is a spectrum including unstable angina, unSTEMI and STEMI patients. It is a cyclopentyl triazole pyrimidine group. And it acts by reversibly binding to P2Y12 receptor by inhibiting it. Ticagrelor inhibits the platelet activation and aggregation by reversibly interacting with P2Y12 receptor to prevent signal transductions. Ticagrelor and cangrelor directly acts and it reversibly inhibits the P2Y12. Remaining antiplatelet, ticlopidine, clopidogrel and prasugrel, they causes irreversible P2Y12 inhibition. Absorption, it can be taken with or without food. Median time of maximum plasma concentration is 1.5 hours. Metabolism, it is metabolized by CYP3A4. Excretion mainly by hepatic route, and its active metabolite is eliminated by biliary routes. Maximum inhibitory concentration effect of ticagrelor can be reached at around 2 hours, and it is maintained for at least 8 hours. Switching from clopidogrel to ticagrelor increases the inhibition of platelet aggregation by 26%, and if we switches from ticagrelor to clopidogrel, it is decreased by 24%. Adverse effects mainly include dyspnea, hyperuricemia and ventricular pauses. It is mainly attributable to the interference with adenosine degradation and inhibition of erythrocyte adenosine reuptakes. The reversible interaction with P2Y12 receptor of sensory neurons may also lead to perception of increased breathlessness. This is a trial comparing ticagrelor and clopidogrel adverse effects. Dyspnea is more in patients taking ticagrelor group. Coming to dual antiplatelet guidelines, American Heart Association guidelines, the recommendation in ACS patients, I am going to discuss only on ACS patients. ACS patients can undergo the following ways of treatment: CABG or fibrinolysis or medical therapy or PCI. If the patient undergoes CABG, dual antiplatelet should be given for 12 months and fibrinolysis also minimum for 14 days and ideally should be for 12 months. Medical therapy also 12 months for dual antiplatelet, and PCI also. PCI it can be done with BMS or DS. Both for acute coronary syndromes, 12 months duration should be given. This is a history of antiplatelets. Initially aspirin was aspirin, after the ticlopidine, clopidogrel, prasugrel and ticagrelor. Ticagrelor is the newer antiplatelet. The blue lines, blue dots indicates the trials done with ticagrelor. The recommendation for antiplatelets in STEMI and NSTEMI, clopidogrel is all antiplatelets are class 1 indications, but the level of evidence differs. If it is a STEMI, prasugrel and ticagrelor were recommended over the clopidogrel. If it is NSTEMI, clopidogrel is recommended as class 1A evidence. The algorithms for switching between P2Y12 inhibitors in the acute setting. Acute is acute MI within 30 days of onset of MI. If a patient is taking clopidogrel, if we want to convert to ticagrelor, we have to load him. Here loading dose should be given with ticagrelor irrespective of the prior clopidogrel dose. If initially patient is taking ticagrelor, and if we want to convert him to clopidogrel, we have to load him for 600 mg of clopidogrel 24 hours after the ticagrelor dose. In the chronic setting, chronic is more than 30 days, there is no need of loading dose. We can give directly maintenance dose of 90 mg BD. These are the guideline recommendations. Class 1, there is a class 1 recommendation for loading dose of P2Y12 receptors before the PCI. Any antiplatelet P2Y12 can be given. It can be clopidogrel 600 mg, prasugrel 60 mg, ticagrelor 180 mg. In patients undergoing NSTEMI, either by early invasive or ischemia guided therapy, ticagrelor and clopidogrel were recommended. If the patient in the NSTEMI patients itself, ticagrelor is preferred over clopidogrel. It is a class 2A indication. And prasugrel recommendation over clopidogrel is also a class 2A indication. Prasugrel should not be given without the coronary anatomy being known. It is a class 3 indication. These are the trials done for different and P2Y12 inhibitors. Mainly for ticagrelor it is Plateau and Pegasus. Antiplatelets in ACS, the recommendations for antiplatelet therapy, aspirin is indicated in all ACS patients. The recommended P2Y12 receptor antagonists in NSTEMI, ischemia guided with clopidogrel and ticagrelor. If it is invasive guided, we can, if the coronary anatomy is known, prasugrel can also be given. If primary PCA for STEMI, any of the antiplatelets can, P2Y12 receptors can be given. If the patient underwent only a fibrinolysis, only clopidogrel is recommended. Ticagrelor in ACS, the following trials were done: Plateau Trial and Atlantic Trial. Plateau includes both NSTEMI and STEMI patients. It compares ticagrelor 180 mg and clopidogrel 300 mg, and the risk and outcomes were measured in terms of cardiovascular death, MI, and stroke. It shows that ticagrelor is superior to clopidogrel. Atlantic trial involves the ticagrelor and placebo trial, and it shows the ticagrelor is superior to placebo if it is given in the ambulance itself. This is the trial showing Plateau Trial. It involves 13,000 patients. Clopidogrel patients were divided into nearly half of patients into clopidogrel and ticagrelor. They were followed up for 6 to 12 months. Conclusion: ticagrelor is more effective than clopidogrel for continuous prevention of ischemic events and stent thrombosis and death. The Atlantic trial, it is a negative trial. It shows that even if we have given ticagrelor during the ambulance, it does not improve the myocardial perfusion pre-PCI, but it has favorable response in terms of prevention of stent thrombosis over the placebo. This is Tios, another trial showing Tios-STEMI style. It is ticagrelor monotherapy. Normally we will give dual antiplatelets for 12 months. This studies compared a monotherapy of ticagrelor after 3 months of DAPT and ticagrelor based DAPT versus aspirin in STEMI. It causes there is no significant difference in MACE. Pegasus is Pegasus TIMI 54. It shows we can try ticagrelor 60 mg after 1 year of dual antiplatelet therapy. Given the high risk patients, after an initial MI, ticagrelor can be given at 60 mg per day, 60 mg BD for several years for beneficial effects. TREAT trial, it shows after fibrinolysis, patients can be treated with ticagrelor, but it compared ticagrelor and clopidogrel, but there is no, it is a negative trial, there is no benefit of ticagrelor over clopidogrel. ICER React 5, it compared ticagrelor and prasugrel. It shows prasugrel was superior to ticagrelor. Popular CABG trial showed the evidence of ticagrelor was not superior to placebo after CABG in venous grafts. This is done in 2020 and 2022. Another trial came from AHA, and it shows that there is some benefit of ticagrelor in saphenous venous grafts. Thank you.